Hi, I'm George Perry, and we're going to look today at Dental Implants A to Z Section 6. Here we want to really take a closer look at maximizing aesthetic potential. Of course, from a biologic point of view, there is an ideal position for the implant. We can't always achieve that. I like to understand before we get into treatment what those limitations are, but we look at that carefully. We can talk to the patient, we can talk to the surgeon, we can work out a plan to achieve the best possible outcome. Our goals certainly should be identified as positive bone volume, ideal implant position, resulting in stable and predictable peri-implant tissues. All those things are important. Working with a great lab to create the aesthetic contour, shape, and color of the restoration. Patient acceptance comes from their understanding what the limitations of the treatment might be and their understanding of the value of the treatment. Once we do all those things together, there still are challenges. How do we manage it from a restorative point of view? Dr. John Kois taught us that we can look at some cases from a more favorable point of view, from an immediate implant placement idea, where we look at the free gingival margin, we look at the type of tissue, we look at the amount of bone, and again, it helps us correlate whether we can even do an immediate. That can lead to an aesthetic outcome. We can look at it from a restorative point of view once the implant is placed. What is the limitations of the case? Do we want to restore adjacent teeth? Do we want to do crown lengthening? What are all these different factors? And I've found over the years, if we talk about this during the treatment planning phase, get the patient on board, if we run into these challenges, it's not as big of a challenge for the patient. Probably the most important thing for us to look at is the implications of implant placement when they don't meet our biologic goals. When the implants are too close together, what is our expectation? And of course, on this case, we don't have a dental papilla. How do we manage that? Can we manage it? Does the patient accept that? Do they want separate teeth or splinted teeth? All those things need to be really reviewed. When we have the classic missing anterior 4 teeth, where should we place our implants? Ideally, I would like to have them alternating, maybe 7 and 9, and we'll have Pontics in 8 and 10. In this case, there was reasons we had to place them in 8 and 9, and we can get a good result managing this case. So each case is different, and each case has reasons for why we do them. Here's a case that Sasha did, and amazing bone loss, but using bone morphogenic protein with implant placement and really minimal bone, was able to achieve really a spectacular result. So here we have this great synergy between surgical management in really a spectacular way, and then restorative, really it was actually fairly straightforward because the implants were placed ideally. And when we look at 5-year follow-ups and we see how the soft tissue has stayed, how the bone has stayed, this is the sort of result we want to see. Our goal is to have aesthetics that aren't just for the moment of our insertion of the restoration, but it's the long-term look at the patient. And that's what we're going to look at today.
For more education programs, visit the Guide Institute at www.guidedental.com.